thank you for having. I have to say, visiting the Stanford campus when I started here as a grad student in Ted Shortlift's, what was before was even called medical informatics back in 1984, we were in two World War II trailers a couple feet from here. So the physical plant has certainly changed. So ONC is a staff agency within Health and Human Services, and we're in charge of, I guess, the regulation and the encouragement and the coordination of electronic health records. And as I think everybody here knows, that's been a bit of a long, arduous journey. And for a variety of reasons, mostly related to how we pay for healthcare in the US, the electronic health record, which of course is our central data store for health information, has really evolved to be more of a billing tool and a billing documentation tool than really what we might think of as a native store of actionable clinical data. Obviously, there's a lot of clinical data in there. Vast progress has been made, but there's a definite flavor certainly in all of the text notes around billing. And if we look broad picture at EMRs, I went into this field. The reason I actually went to Stanford after my residency was to actually automate healthcare so that we could get out from the no value add activities that are so much a part of clinical care, sort of so-called SCUT. We haven't yet to achieve that, and I think we have yet to really make the EMR a tool for deep and fundamental patient engagement. We had a number of great discussions this morning about social determinants of health and thinking about how to get patients back into the game. We need modern computing for that. We just need modern computing. This has not escaped Congress. So in December of 2016, the Congress passed the 21st Century Cures Act. Now, a lot of that act has to do with FDA and clinical trials, but there's a whole section in there on healthcare information technology. And just to do a little time warp, as you remember, December 2016, there was a presidential election. I think probably it was safe to say it was a surprise to everyone on both sides of the aisle. Of what happened there. I remember when I had my interview with Tom Price, I was joking with him. I said, I never expected to see you here in the seat as you were sitting at his secretary cabinet desk. And he said, yeah, me neither. So it was certainly interesting. The Cures Act, though, was passed almost unanimously by Congress, 390 plus votes in the House, and 92 votes, I believe, in the Senate, signed by President Obama. I can absolutely assure you that President Trump, Secretary Azar, the entire administration is very much engaged in the goal of the Cures Act, which is to get patients back into the game electronically. That means today getting patients' data on their smartphone. How do we go about doing that? That is really the nature of the game that we have to have. And Congress came up with a couple very specific provisions here that I think are really going to fuel the entire discussion of big data. Because, some of the talks you heard earlier today, it's worth understanding that those application programming interfaces and how they got that data was really pretty much one-off or very vendor-specific things. There really weren't sort of broad standards there. So how do we get to that? That's really empowering. The three things that Congress has in Cures that ONC is implementing. One is hooking the health information exchanges together, trust exchange framework, common agreement. That's a bit of a deep technical dive. I just mentioned it. If anybody is interested here, my guess is this is not your foremost interest. The second is Congress heard a lot of complaints about what's called information blocking, which is that providers will not share their data. And as you've observed, for those of you who are, economic observers as well as computational or clinical observers, in much of the American delivery system, the name of the game has been to buy as many hospitals as you can and become a price setter to payers. That is the name of the game. Obviously, one of the concomitants of that is a question of leakage, right? So how do you get the patients in? In that kind of an economic environment, sharing information is not necessarily the highest priority. So how do we do that? So Congress made information blocking of clinical information to patients illegal. In our proposed rule, which is out for public comment till June 3rd, healthit.gov, you can take a look. There's a couple simple PowerPoint slides that will give you the flavor of it. Unless you are a lawyer, you're probably not going to want to parse the 700 pages of explanation there, but the slides will give you the gist of it. So if you have a chance, take a look at that and put in your comments by June 3rd. That information block, and we've put in some exceptions on that, but the real game changer here that Congress came up with is the requirement that there be application programming interfaces without special effort. So think about, if you're designing, what does that mean? Application programming interfaces without special effort. What that means really has to be you're going to have industry standard APIs. That is really what that means. And in the smartphone world, that really is RESTful, JSON, and FHIR. I'm guessing a lot of folks know that, but they're very straightforward standards. They're materially easier for programmers who are not deep into decades of healthcare experience to implement. So we want a broad app economy. And the ONC, the Cures rule, our goal is to have an app economy. And what will this do? Well, first and foremost, it'll allow patients to shop for their care. Increasingly, we have a core data set that we're starting with structured data. Increasingly, it will allow patients to get their data on their smartphone and shop for it. We're exploring some of the ways to get price information in. In our rule, there's a request for information on how we might represent price information. More on that in a bit. But it is patient empowerment. And of course, patient empowerment may be on shopping. Patient empowerment may be on engagement, and it'll come in all kinds of forms. It'll be, where do I want to get a surgery or something? How do I manage my diabetes? How do I manage my coronary artery disease, CHF? I think there'll be all types of things. The technical standards are OAuth 2, very secure standard. It is the patient who gives the consent to the app. It's the patient who chooses the app. Under HIPAA, the big privacy law, once the patient has that data, it is their responsibility under the HIPAA right of access. There's a large national discussion about secondary uses of data. You're all aware of that. I think there'll be some of this. There's a lot of it floating around on the Hill. Ultimately, I think Congress is going to have to figure out what our country's approach is in comparison to GDPR in Europe, the California rule, the other state rules. But that information, the way we have this designed is that patients control their information, have access to it. And we want to get patients to be active participants rather than the passive participants managed by third-party payers here, which has really been the norm in the last 55 years or so since the start of Medicare. Those APIs, of course, will really be also some of the fundamentals of big data, as the conference has shown. Specifically, what we're doing there, what was identified, is that the typical APIs are really queries with an N of 1, number of 1. So we're working with all of the big payers who, interestingly enough, have a devil of a time getting the electronic clinical information on your care, believe it or not, to build out population-level queries so that they can look at an entire population. Now, those things, we talked about the individual right of access, which is a patient right under HIPAA. Population queries of whatever format will need to be either IRB or signed agreements under HIPAA between the providers known in HIPAA speak as covered entities and other parties who in HIPAA speak are known as business associates. So those are not on demand, they're negotiated service level agreement type of thing. But we think this is going to provide a very different, very empowered way of looking at healthcare. As we look at medical data, right, in this conference, it's worth noting today, if you look at the landscape, in the broader American landscape, clinical data sits in 3 disconnected silos. One silo is sort of the clinical data, right? So lab information, imaging, DICOM, the charts, right? So that's one silo. The second silo, which is not really, amazingly enough, much connected to the first, are in quality measures, which are really one-way conversations to payers. And the third silo, which is not really connected to either of the other two silos, is financial data. So the X12, the electronic data interchange, all of this claims, payments, remittances data. So we have some interesting opportunities, not enough time to talk about them, to start thinking about getting all of this into an integrated modern data stream that is integrated, and that will allow things, for example, machine learning, to eventually think about replacing some of these quality measures, which are often gamed, with the broader analytics. Jeff Dean's talk this morning gave a flavor of how machine learning on vast amounts of data is more predictive than heavily classic statistics-based approaches on individual data. So we see the APIs and interoperability really framing a much broader discussion of healthcare and getting healthcare back where the rest of the economy is, frankly, today. As we look at AI, and again, obviously I'm a fan of that. It's very interesting seeing the second AI revolution having been on the tail end of the first AI revolution. Some of the claims could be verbatim substituted from 1984 to today, so it's a very interesting historical thing. And then, as now, often we focused on diagnosis. But I would throw out that the real big data issue to solve in American healthcare is affordability. Not diagnosis, it's not even interoperability, it's how do we afford care? So I think a focus of artificial intelligence on things like how do we get value, cost comparisons, just the vast sea of inefficient, labor-intensive operations is really what I would throw out to you to think about as part of this broad future of healthcare. It is a very exciting time. I think the data standards that we're pushing in conjunction with CMS has a companion interoperability rule asking the payers to expose all of their payment data, as well as their last 5 years or whatever other clinical data they have, can combine together to really have a very active, live, real-time operational feed to build new products facing patients. Both rules, which are in sync through the White House and Health and Human Services, are open for public comment until June 3rd. Our Trust Exchange Framework rules open until June 17th. I encourage you to take a look at those, put in your comments, and there's an official way of doing it. It's a extraordinary time to think about getting modern computing throughout American healthcare, right? Not just the Stanfords of the world, but to all Americans. And I think we have time for some questions. I believe the rest of the gang is coming out. Professor Baker and Allison. We're coming out. Okay.
Yes, thank you, Don.
All right, thank you.
Let's thank Don for his comments.